Welcome to this session. I'm Neil Steetet. I'm a clinical neuropsychologist from Oxford, and it gives me great pleasure to welcome our two speakers this morning, Professor Richard Brown and Professor Eileen Joyce. And Professor Brown is a clinical neuropsychologist. He's professor of neuropsychology and neuroscience at the Institute of Psychiatry and head of psychology there. He's published more than 200 papers looking at diverse aspects of brain disorder, and with a particular interest in movement disorders and indeed in Parkinson's disease. And within that, a particular interest in developing and testing novel methods of psychological treatment for the non-motor symptoms of Parkinson's. And that's what we're going to be treated to a talk about this morning. So I welcome Richard Brown.
Thank you very much, Niels. Okay, can people hear me from this mic? Okay, so as Neil said, my research has for many years been really pretty much focused around diverse aspects of Parkinson's disease, starting with very early days when I was working with Professor David Marsden and studied my PhD under him many years ago. And I've continued an ongoing interest and a sort of lifelong fascination by the non-motor aspects of Parkinson's, moving more towards the sort of clinical end in more recent years. And the title I was given was really talking about psychological therapies in Parkinson's disease. I'm slightly concerned that this is a research update, because if that's the case, we could probably be finished in 2 to 3 minutes, because there really has been very little. And although there is some ongoing research, as Niels has indicated, I'm involved in, we're sadly too far away from being able to provide any of those results. But maybe at a future meeting in 2 or 3 years' time, I'll be able to give you a real update on progress. So, in terms of the learning outcomes, I just stated here, I hope if you don't already have this knowledge and information, we'll hopefully understand the complexity and clinical significance of the non-motor aspects of Parkinson's, because I think it's in these areas where the greatest opportunities lie for psychological interventions in Parkinson's disease. And briefly, as much as I can in the time that's available, look at some of the evidence relevant to psychological approaches to management, but more importantly, perhaps to point to some of the evidence gaps which are still present in the literature. While I'll be focusing mainly on talking about depression and anxiety in Parkinson's disease, I would like to suggest there's a much wider range of potential psychological targets for intervention. And we'll look at some of those and really try to formulate those in terms of a broader, more holistic model of psychological distress and disability in Parkinson's disease, and how psychological approaches can work in those ways. And briefly then, just to touch on some perhaps emerging treatment approaches that we may look to. There's some really important $64,000 questions about how we access these treatments for our patients, and I think that may be something, if we've got time, we can have a very fruitful discussion with the audience. So Parkinson's disease isn't unique in this sense, but it is an enormously heterogeneous condition. And this statement from a patient with Parkinson's disease on the Parkinson's UK website is that every individual has a different Parkinson's disease. There is almost no one condition. And that's true not just in terms of the motor phenotype, but also a wide range of clinical progression outcomes, response to treatment. But what I'll be focusing on for this talk is the bottom bullet point there, which is the very complex profile of non-motor symptoms or non-motor aspects of the condition. So on the left, I've put up a whole range of symptoms of non-motor phenomenology which are associated to a significant degree with Parkinson's disease. Not uniquely to Parkinson's disease, but because all chronic neurological conditions will have a similar range of symptoms. But Parkinson's disease seems to be particularly marked by the number and diversity of these. And the numbers I put up there are limited only by the number of circles that PowerPoint allowed me to put in this form. There could have been many more. But what we see is the well-known ones, the cognitive changes, the apathy, the depression and anxiety, but also psychosis and impulse control disorders, But then we get all the sleep and sleep-related problems, fatigue, pain, hyposmia, gastric problems, constipation, gastric pain, and a whole range of autonomic symptoms as well. So all of these are very much part of the profile, the symptom profile of patients in terms of diagnosis and clinical management, but equally these are the sorts of problems which patients themselves really complain about. These are the things which are often more important to patients than the motor symptoms, but equally are some of the more intractable problems in terms of clinical management. So if we look at predictors of disability, predictors of poor quality of life and care burden, it's these sorts of symptoms, either individually or collectively, which seem to be the major drivers. Sadly, at the moment, I think we still do have a predominantly medical or biological approach to care for all of these symptoms, not just the motor disorder. And sadly, the medical management, when it is available, is often suboptimal because maybe the treatments aren't that good or they're not applied suitably. And these symptoms still do remain undetected and undertreated. So we've got a very burdensome condition with increasing burden, with disease progression, but increasing levels of disability and associated poor outcomes for patients and for their families. So what does NICE have to say about these symptoms? Well, sadly, very, very little indeed. And it's not because I think the people writing the guidelines felt that they were unimportant, but they're, of course, guided by the availability of good quality empirical evidence on which to make recommendations for evidence-based treatments. So there's a lack of evidence, really, pretty much for all of these non-motor symptoms in Parkinson's disease. And where guidance or suggestions are made, it's typically cross-referencing to other NICE guidance. So for depression, for instance, the only recommendation is to refer to the guidance for the treatment of depression in people with long-term medical health conditions, nothing PD-specific. And what I found particularly disappointing, but perhaps not surprising, is that the latest NICE guidance for Parkinson's disease management was completely silent on the role of clinical psychology or psychotherapeutic options for the management of non-motor symptoms of Parkinson's disease, with the exception of one reference to the possible application of CBT for the treatment of impulse control disorders. So we're really in an evidence vacuum here, sadly. So why do I think that psychological approaches have value? Well, I think they have value because they can be provided as an adjunct or sometimes even as an alternative to the available medical management which we do have available. And I think they take a different perspective, a different approach. So whereas typically in the management of Parkinson's disease, as we've heard already with epilepsy, it's all about symptom reduction, reduction in intensity and frequency of symptoms. But the psychological approach really focuses not just on symptom reduction, although that can be important, but really trying to reduce distress and excess disability and burden associated with symptoms, both physical and non-physical. And psychological approaches to care, typically the predominant cognitive behavioral approaches, really focus on factors which increase the vulnerability of patients to experiencing distress, or which exacerbate it or maintain those symptoms. So it gives us really a sort of transdiagnostic, a sort of etiology agnostic approach to looking at the problems which patients are facing in a holistic way, and therefore gives us a way to home in on things which we may not have evidence for, but we can have very good idea of the sorts of models and treatments we can apply. And I think even in the absence of evidence from Parkinson's disease in terms of randomized controlled trials, we can look to repurpose approaches that have been fruitful in treating symptoms such as these in both physical and non-physical health conditions to see how we can apply similar approaches, similar models in Parkinson's disease, while hopefully waiting for the evidence to come along, but there's no need to wait forever. So I've just popped up there. These are symptoms which I think psychology already helps with in terms of patients, with evidence in other conditions outside of Parkinson's disease. So no reason why we shouldn't pursue these quite actively in terms of our clinical care. So let's focus on depression just for a bit. I think the basic guidance, as I've indicated, is the management of depression in people with long-term health conditions, and NICE guidance is very much the stepped care approach in which psychological interventions is part and parcel of the intervention strategy, in addition to pharmacotherapy when indicated at all levels, from persistent subthreshold depressive symptoms, mild to moderate depression, right the way through to the much more severe end of the spectrum. So the stepped care approach is that psychological interventions, with or without medication, should be the first thing that we should be thinking about when looking at any person with a long-term health condition. And that, of course, includes Parkinson's disease, but I think for all sorts of reasons, often is not followed. Before thinking about CBT, psychological approaches for the treatment of depression and Parkinson's disease, we need to contextualize that in terms of how good the medical management is. And this is a meta-analysis done a few years ago now, looking at RCTs of antidepressant medication in Parkinson's disease, typically SSRIs, but a few SNRIs and tricyclics. And what we see is that there is a benefit of treatment, as we would expect, but the effect size is not great. It works in Parkinson's disease, probably to similar levels of efficacy than they work in other groups. So we have got positive but modest efficacy. In terms of the best available evidence to date, is this study from 2012 by Richard and colleagues, three-arm trial comparing placebo with paroxetine and venlafaxine, and showing over a 12-week period, 13-week period, superiority of both drugs over placebo. So suggesting really that these drugs work in Parkinson's disease. There's no reason not to use them. No particular advantage of either drug over the other. What is often not reported, though, in trials in Parkinson's disease, and perhaps other conditions as well, is the actual response rates and full remission rates. And here the story isn't that good. Here we see here the 50% reduction in symptoms at 12 weeks. And we see, even though there is a small superiority of the active drugs over placebo, these differences are not significantly different, and the same is true in terms of full remission. So what that tells us is these drugs can work in a group setting, but an awful lot of patients are not showing a significant treatment response, and certainly not full remission. So 50% or more of patients are not responding adequately to either of these drugs. And this isn't specific to Parkinson's disease. It's pretty much what we expect to find in most trials, non-PD trials. So what about CBT? If not all patients are benefiting from drugs, can we have adjunctive CBT to help patients, or to have it as an alternative? And this remains to this day the one and the only adequate randomized controlled trial of CBT for Parkinson's disease depression, published in 2011. It's fairly characteristic in that it's a comparison of CBT versus treatment as usual, which effectively means no treatment. So it's not a good comparison. It's not placebo-controlled in any way. So we'd expect these sorts of seemingly impressive effect sizes to be much reduced had we had an active psychological arm to the study. But what was, I think, meaningful is that there was substantial symptom reduction. Response rates of about 56%, similar to that we were seeing with pharmacotherapy from the placebo-controlled trials. This treatment was interesting in that it wasn't an off-the-shelf CBT manualized treatment just for depression given to people with Parkinson's disease. It was adapted to reflect the sorts of problems which patients were experiencing and tailored to the needs of an older and often more cognitively challenged group. So it involved aspects of physical exercise, sleep hygiene, behavioral activation, doing more positive events, worry management and relaxation training to tackle some of the anxiety and stress-related aspects. So the depression-specific cognitive elements actually were quite a small part of the intervention. So this package, which was applied in a more manualized way, every single person got the same treatment, can show a useful effect. The limitations of CBT for Parkinson's disease are really the same as the limitations of CBT as applied in any group. the effect sizes do tend to be relatively small, and we still find this stubborn non-response or partial response rates. Also not shown here, and no evidence in Parkinson's disease, we know from CBT for depression, there's a high level of relapse and recurrence. Again, not just CBT, but pharmacotherapy as well. But also CBT, or even modified CBT, will not be suitable for all patients with Parkinson's. It may not be acceptable and may not be accessible to them either. If we look at predictors of poor outcome, and this is applied to psychotherapy and pharmacotherapy, there's a range of factors which we know are predictive of poor outcome in terms of response and remission rates. People who do best are the people who are most depressed at the beginning. So relatively low or threshold levels of depression, people don't tend to respond so well. Those with high levels of comorbid or co-occurring anxiety, those with physical health conditions, fatigue, executive dysfunction, and low socioeconomic status all tend to do worse in pharmacotherapy trials. And I think we can tick all of these boxes in people with Parkinson's disease. So we could almost predict from the outset that Parkinson's is a group who are probably almost predisposed to show if not a poor, but a sort of partial response to pharmacotherapy. If we look at predictors of recurrence and remission, and this is true again of pharmacotherapy and psychotherapy, that people recur or remit in the following months if they've still got persistent, stubborn, subthreshold symptoms of their depression. Low mood, irritability, low motivation, fatigue, social avoidance, sleep disturbance. The more of these symptoms which fall below the threshold for clinical diagnosis a person has, the more likely they are to relapse later. Okay. The other things are more psychological, so people who have persistent dysfunctional attitudes about their life and their condition, and those people who have residual rumination also tend to do bad in the long term. So I want to focus a little bit on rumination, because I think it's one of the areas where there's emerging evidence this is a fruitful target for new psychological approaches. So this is a simple cross-sectional study which we did in a group, convenient sample of people with Parkinson's disease, looking just at the relationship between the severity of their current depression and a range of psychological factors which we think may be important, and to see which of these are the best predictors of overall depression severity. And what we found, first of all, was that how disabled the person was by their Parkinson's disease actually was a very poor predictor of their depression, which is not a new evidence, but perhaps challenges some of the models which both clinicians and patients may have. The presence of dysfunctional attitudes and assumptions actually was very, very unimportant. So having a therapy which really drilled down and targeted those may not be the best approach for the management of depression in Parkinson's disease. But what we did find was that the level of trait rumination, of avoidance, and particularly the degree to which a person spends time focusing on their symptoms, that these were the factors which seemed to be driving the severity of their depression. And in fact, the adjusted R-squared, these factors alone could explain almost 3/4 of the variance in depression severity. Anxiety in Parkinson's disease is understudied, even though I think from our clinical experience, it probably comes across as more important and more relevant to patients than depressed mood. The most common presentations tend to be GAD or GAD-like, but also with panic and social anxiety and agoraphobia. And because we find this very strong co-occurrence of anxiety and depressive symptomatology, I would like to suggest we really should be formulating these as a sort of distress disorder rather than trying to put the patient in one or other box and talk about comorbidity and putting boundaries between the two. I'm going to skip over the rest of that slide in the interest of time. In terms of the presentation of the mood states in Parkinson's disease, this is just a bit of data from a large longitudinal study which we completed a few years ago, looking at the phenomenology of mood and mood-related symptoms in Parkinson's disease over a 5-year period with annual follow-ups. And what we found using a data-driven approach is that a good proportion of patients showed very low levels of threshold symptoms. Any of these symptoms along the bottom side, they're a bit small to read. But then we found three other classes of patients who could be defined by the patterns in their data rather than by diagnostic categories. First, a group of patients with moderate levels or moderate probabilities of anxiety-related symptoms, in particularly subjective tension and worry and poor concentration, very GAD-like symptoms, but with low levels of depressive symptomatology. And then there was another two classes that showed a combination of both depressive and anxiety of symptoms with more severe and more moderate. So we can look at these in terms of either psychologically healthy and resilient patients, those who show a relatively defined anxiety-related state, and those who show a combination of the two sets of symptoms. And if we look across the 4 years of study in these 500 patients, we see that the proportions of patients in one of these distress-related conditions stays fairly constant, around 40%. The other thing we found, if we looked at the transition of patients from one of these classes to another, is in fact there was a high degree of stability. The patients who were psychologically healthy stayed psychologically healthy, which was great, but those who were in one of these distress classes tended to move between them or stay in the same class rather than becoming healthy at some point over the period of time. And similarly, not many of the healthy patients actually moved into one of these distress states. So these are patients who have long-term distress conditions, despite, in many cases, being on pharmacotherapy for their mood. Okay, so if we go back to the NICE guidance, what does it say about anxiety? Well, it doesn't say anything about the treatment of anxiety, and what I thought was fascinating, the word anxiety is not mentioned even once in the NICE guidance, which I think was a surprise to me. So that was just the Google search of that document. Okay, so what can we do about treatment? Well, we don't have the evidence, but we do have really good models, particularly for anxiety, in other conditions, which I think are very easy to repurpose and adapt for use in Parkinson's disease. So we have very good evidence-based models of social anxiety and health-related anxiety and GAD. If these are the predominant symptom profiles in Parkinson's disease, can we use these models to develop new treatments and apply them even while waiting for the evidence of efficacy to come along? I'd just like to point people's attention to this model. This was published a few years ago by Egan and colleagues Ken Laidlaw and Sergio Stein, really trying to formulate a model which captures some of the phenomenology and some of the evidence which may be helping us to understand and explain the maintenance of depression and anxiety or distress in Parkinson's. And it is very much focusing on factors such as rumination and worry and symptom focus and hypervigilance and avoidance. Because I think these are really the targets that we need to be looking at in terms of treating distress in Parkinson's disease, rather than maybe the old sort of style CBT approach of looking at thought content. I'm going to skip over this at the moment. Just to say that this is really very much the direction of travel of cognitive therapy now, not specifically in relation to long-term health conditions, but in terms of trying to enhance the effectiveness of CBT and certainly trying to tackle some of the challenges around relapse, recurrence, and non-response. So there's a raft of so-called third-wave CBT treatments, which are being developed from rumination-focused cognitive therapy, metacognitive therapy, mindfulness-based approaches, ACT, all of which I think have real application in the context of people with long-term health conditions, and particularly Parkinson's disease. So I think what we can see of these non-motor symptoms, really these are drivers of distress in patients with Parkinson's disease. And we know from the synergies that we see in our patients that the more distressed a person is, the more likely these are to be driving non-motor symptoms and motor symptom severity as well. So lots of good evidence from Parkinson's disease that in terms of associations, that high levels of anxiety in patients who have hallucinations and psychosis, that anxiety and stress is linked as well to impulse control disorder, to fatigue, sleep disturbance, and so on. So if we think about targeting distress, the hope is that we'd actually be able to have some very positive outcomes of these symptoms themselves, which are themselves the drivers of the distress, but also being maintained and worsened by it. So we can try to reduce the symptoms, but also by addressing distress, hopefully, in the long term, reduce the excess disability which patients are experiencing. Okay, so I think that's my last slide here. I think as clinicians that perhaps rather than trying to label and diagnose patients as being depressed or anxious, we should be looking for patient distress as being the key marker, but also excess disability, which may be caused by these non-motor symptoms, but which are, I think, tractable to psychological interventions. The challenge here is identifying and finding care pathways to find the psychologists and other therapists who are able to adapt their knowledge and skills and apply it to Parkinson's disease, unless they're working very much in that setting. And it could be, the hope is that the new integrated care services through the IAPT service may be one avenue for this. Okay, thank you. Sorry. On the button, but on the button, sorry.
Thank you very much, Richard. And we have time for some questions.
Thanks very much.
We have a microphone.
I'll shout. I thought I'd ask you a question that you posed at the beginning. How do you think you can bring some of those services in? We often don't get access to psychological therapies, even for functional patients or for people who are even more debilitated by their distress. How do you think we could get that into NICE, and what drivers would you think of using?
So on the day-to-day, you mean how we, as clinicians,
How do we get it included into the normal care pathway for the NHS so that we can access it?
It's a double bind, isn't it? You know, the commissions will say, show us the evidence, and we'll include it. I think the lessons here, they cross all of the long-term health conditions. The vast majority of them lack the evidence base which is necessary. So it's almost, I think, maybe sort of the neurological conditions, an alliance of the neurological conditions, and specialist services may be needing to work with commissioners at a local level rather than individual disorders like epilepsy or Parkinson's disease, each trying to get a little bite of the cherry. So I don't know whether that's it's more a strategic, local approach.
And do you think there's research funding for that?
That was a wonderful talk. It's very, very clear.
Thank you.
Can I ask you about this issue of non-responding, which I think, as you alluded to, there's no great surprises in either the rates in the CBT group or on the pharmacotherapy group. But that 50% roughly of non-responders, are they the same people? In other words, are there some people who get better whatever you do and another group of people who don't? Because that's the big question that always bothers me in clinic, because it's easier for me to start a drug, so I do. And then I think if they don't work, shall I go on and start treating them with CBT? And I just wondered, from your own personal experience, I appreciate there's maybe not the data to answer the question, what your experience of that is.
I tend to see people who have been on pharmacotherapy and remain on it, but still remain disabled, upset, distressed by their conditions. So I haven't got any personal evidence to see, if you want sort of de novo, that original decision making. Normally they all reach me in my service after having been around the houses a few times as well. But often haven't been on antidepressants for maybe 5-10 years. Maybe they're doing something, but they're certainly not tackling all of the problems.
And when you treat them, do they get better?
Well, what I end up treating them is not what they get referred to often. So very often it's poor adjustment and it's relationship problems rather than depression. Get my CBT model and apply it. And they get better in the sense that they live life better and there's less discord within the family. And for me, those are the sorts of outcomes which people really want rather than a lower score on the Beck Depression Inventory, which also does happen. But sometimes they remain a bit fed up and a bit morose and depressed, but they're actually leading much more active lives, or there's less stress around their lives.
And I think we have a question at the back. That'll have to be the last question.
Thank you. I'm just wondering, to what extent does age of onset of Parkinson's predict clinical outcome in terms of these non-motor symptoms?
I think I probably wouldn't want to say for all of the symptoms, but certainly in terms of poor psychological outcome, then I think there's a sort of a trend and general feeling that those people who develop Parkinson's disease earlier in life, certainly when they have families, where they have jobs, where they have a wider range of social activities, the distress and the adjustment-related problems in younger people developing Parkinson's in their 30s, 40s, or even early 50s is worse than those people who develop Parkinson's and the non-motor symptoms, later in life. So I think it's an added sort of complexity and psychological threat to Parkinson's disease when it happens younger, and that's one of the things which I think a psychological approach is much better able to accommodate than a more medical management.
Excellent. Thank you very much, Richard.
Pleasure.